Hello, everybody. Welcome to our year-end Twitter Spiz on MSF's response in the Ukraine, Nigeria, and Haiti. MSF, otherwise known as Médecins Sans Frontières or Doctors Without Borders. I am your host today, Joseph Beliveau. I'm the Executive Director of MSF here in Canada. We have about 30 minutes for a discussion on these three contexts today. Please share the link, retweet, like it, and help us promote the session today, especially if you get something useful out of it. I'm joined by three colleagues today whom I will introduce in a few moments. But first, just a few words of background. So MSF is, as many of you I'm sure know, is an emergency medical humanitarian organization. We're working in about 70 countries around the world at present. This year in 2022, our teams have responded to numerous emergencies. Very often we're working with communities who are affected by violence, by repression, deliberate neglect, also climate and environmental factors as well. One of those emergencies that we've been responding to, not surprisingly this year, is the ongoing war in Ukraine, which has been going on for several years now, but of course really took a dramatic turn in February this year. Since that time, MSF has adjusted its programming and scaled up its emergency response. MSF has been supporting local hospital Ukrainian staff with hands-on training in trauma surgery and burn care, mental health support, and also physical therapy for people who've been directly affected by the violence, including having lost limbs. You may have also heard about the medicalized train. So we've been evacuating people from the heavily affected conflict areas in the eastern part of the country using a train that's equipped with an intensive care unit and hospital wards right on the train. So far, we've transferred more than 2,000 patients to safer places in the country that way. In several countries around the world, and especially across the northern part of Africa and the Horn of Africa and the Sahel region, we've seen really alarming rates of malnutrition this year. In northwest Nigeria, the malnutrition crisis has reached really catastrophic levels. And it's an area that's also affected by violence, by people who've been displaced from their homes. There's been ongoing drought conditions now for many months, which has affected people's livelihoods, lost crops, lost livestock, and soaring food prices. So in MSF in our program so far this year is about 140,000 children who've been treated for acute malnutrition in 5 states in the northern part of Nigeria. In one state, Zamfara State, for example, the rates of malnutrition are 39% higher than they were at this time last year. And the last context that we'll have a look at here is Haiti, a bit closer to home if you're joining us from Canada today. So in Haiti, the political, economic, and security situation really took a dramatic turn for the worse earlier this year. At present, heavily armed gangs are controlling large parts of Port-au-Prince, the capital. Kidnappings are frequent. Violence against civilians are frequent. Many residents remain trapped in their neighborhoods. They're not able to move around freely to access goods and services, including healthcare. And layered on top of that crisis is also at present a cholera outbreak. So to reflect a bit on these three contexts, I'm joined today by Dina Alwa, project coordinator who's working in the Ukraine. I'm also joined by Dr. Simba Tirima, country representative for Médecins Sans Frontières in Nigeria, and Rachel Seguin, medical coordinator who is currently working in Haiti. So if I may, Dina, to kick things off here, MSF has been present in the Ukraine, as I mentioned, for several years now, I believe since 2014. Up until things took a turn for the worse earlier this year, a lot of our programming was for tuberculosis, HIV, people with chronic diseases. I think we've really had to adjust our programming and find a different role for ourselves since earlier this year. What have been the main challenges in reorienting ourselves toward an emergency response in this context?
Yeah, talking about moving from a very stable program of focusing on chronic diseases to emergency, it requires quite a bit of adjustment. One is we needed to get the staff that had the emergency skills. I mean, we as you mentioned, we have trauma surgeons, we have people that are skilled in mass casualty planning and mass casualty triage. So it was really important that we had the staff on the ground that had the emergency skills as well as the supplies. We did some pre-positioning of supplies, and it was really required a different relationship with the Ministry of Health here in Ukraine. It's a very strong Ministry of Health functioning, but obviously the war has created huge stress on the healthcare system. So we were working with the Ministry of Health and finding really where it would be appropriate for us to have our mobile clinics to be able to treat people safely. And as you mentioned, the train, which is moving people out to safer areas for treatment. But we do have quite a few teams that very close to the front line, working in clinics, restoring clinics that have been damaged, and using mobile clinics to reach people who have been under siege for quite some time.
Yeah, great. I can imagine that many contexts where MSF finds itself, we're sometimes the only medical humanitarian responder, or sometimes we're working with very few others around. In this context, as you mentioned, Ministry of Health, a very well-functioning health system previous to all this. So what are some of the niches, like the specific activities that MSF has identified that we should be responding to now, as opposed to the Ministry of Health or some other actors?
Well, the Ministry of Health has actually asked us to share our expertise in these life-saving emergency activities. One of the things that we've been doing quite a bit of is mass casualty planning and training. I mean, that's something we're very good at. We're also working very closely with internally displaced peoples, as the system just was not prepared to handle hundreds of thousands of displaced people fleeing from the front line. I think a third point I'd like to make, that the Ministry of Health has asked us, and we can see clearly there's a need for trauma mental health services. This is a very difficult situation that the people are living through, and there is quite a bit of support needed for mental health. So those are just quickly some of the things that we're being asked for.
Yes, that makes good sense. And this train that we both mentioned now, that it's a very evocative image. Can you bring us there a little bit? How does this train work, and what kind of services are on it, and how does it work?
Certainly. The train has been vital in saving people from very difficult situations and getting them to safety. They're working closely with the government here and the Ministry of Health to make decisions on where people should go. For example, they may be evacuating a hospital, and they'll need to take those patients to the west of the country where they can continue getting treatment. There are people that are disabled, and so the train would take those people. Actually, we recently had about 50 orphans arrive from the train. So the train has a lot of different uses. There is, as you mentioned, an ICU on the train, and these people that are on the train come with their caregivers as well. So I think it's about 8 wagons long, and it takes the patients as well as their caregivers to safety. And the government has been pointing out where in the country in the West is the best place for them to go, and making sure some of the hospitals and facilities here have room for those people. And then we help as those facilities are stressed with this additional burden, that we're helping the staff there to be able to cope.
Mm-hmm. And so this train is bringing, of course, people from the more dangerous and conflict-affected parts of the country into presumably safer and places, I guess, where there's advanced medical care too. What's it for us and for our teams to be working in some of those more conflict-affected areas? How do we manage our security?
That's very important. We're having our mobile clinics go to actually recently retaken areas. So we are driving into areas that have just recently been cleared of landmines, sometimes the day before. And we are seeing people that haven't seen doctors or really anyone in almost 7 months. So people that have chronic diseases or other illnesses or that need to see healthcare, we're there, and we're doing day clinics and arriving to these small villages. Our staff are being trained on landmine awareness because of unfortunately, the proliferation of landmines. And our logistics department goes out the day before, as I mentioned, just to make sure that there is it's a safe route, and we're monitoring the situation constantly, to be quite honest. And we do have air raid alarms, and we do have apps on our phones with alarms. And I think another thing that we're dealing with, and so is everyone here, is winter's coming. It is very cold here. Where I am, it's usually around -3 to -10. It's going to get much colder. And I believe you've heard about the blackouts. So we have very limited electricity, which means no heat, also no hot water, and often no water. So this is a bit of the situation we're all dealing with.
Mm-hmm. Yes, thanks. I was going to ask about that winter situation. I'm gonna move on. I think we could talk all day, Dina, about the Ukraine. I'm going to move on to Nigeria and Haiti, and if we have a bit of time in the 30 minutes, I'll come back with some more questions. But thank you for that. So in Nigeria, so Dr. Simbatirima, we've got this really kind of, I think, massive malnutrition crisis this year that's likely caused by a number of different factors. Dr. Simba, can you just paint a picture for us? What are our teams seeing? Like, what does this malnutrition crisis look like from the ground?
Yeah, we've seen a sharp increase in malnutrition cases admitted to facilities, and some of the more, investigations we've done have been very concerning. Just to give you a very quick picture, as compared to last year, January to October, we've seen an increase of 226% admissions, inpatient admissions for severe acute malnutrition, and 466% increase in outpatient admissions for severe acute malnutrition. Wow. And so between, let's say, March and this time around, we've treated about 140,000 children for severe acute malnutrition. 25,000 of those were admitted with very, very complicated cases. And one of the things that we're saying currently and reflecting upon is that if we were not present in the 5 states where we're working, most likely those 25,000 kids would not have made it, would not be alive. And so it's really been something that is unprecedented. We've been treating malnutrition since 2015 in the Northwest, but we've not seen anything like this before.
And Dr. Simba, what do you think, or what is behind it? Why this year? What are some of the factors? We know it's a violent context. I think some drought. But how would you describe the driving factors of this crisis right now?
Yeah, I think you mentioned some of them in your introduction. We have escalating violence that has caused displacement, and also people not having access to their farms and markets. We have a sharp increase in food prices, generally speaking, in Nigeria. And I'll give you an example. In 2020, a 50-kilogram bag of rice was about $20. Last month, a bag of rice was $80, so 4 times more. And then, of course, global climate change is a reality. The rainfall patterns that were historically predictable are no longer predictable. We have flooding in many places. And so, it's many factors driving this. But violence really seems to be a big factor. Also, health services in Nigeria, and particularly in the north, are virtually non-existent. So most of the folks that are exposed to malnutrition and other comorbidities, including measles, malaria, and the like, don't have access to healthcare. Of course, these are areas also that are impoverished. I was talking to somebody yesterday, and they were telling me, look, I can't even afford to get what we call an admission card to maybe a government facility. It's 100 naira, which is about 10 cents. And so the rates of poverty in this area also are astronomical.
Yeah, thank you. That's really clear. And when I think of 140,000 severely malnourished children, that's a hard number to get your head around, and that means a really large upscaled response from MSF, how do we do that, like logistically, and how do we get to where we need to be, and how does it look?
Yes. First and foremost, I would say this. Look, there are 140,000 or so kids that we treated are the ones that were able to reach us. We are convinced, and from reports on ground, that there are many more who couldn't reach us. So the situation might be even way worse than we think. But reaching these folks is a logistical nightmare and also a security challenge. We are in places where kidnappings are rampant, where attacks, on civilians, especially in villages, are rampant, and killings and highway robberies, kidnappings, and so forth. So we really have to be very careful, and we've had to ramp up our security analysis and really careful about how we respond in these places. In fact, some of our facilities have been attacked in the recent past and looted, and some of our let's say incentive staff, that we work with, have been shot and killed and things like this. And so it's not easy. However, we've been fortunate enough that in most of the places, the facilities where we work, and there are most of them are government facilities, are moderately secure, and so patients can reach us.
And are we able to have contact and sort of get security assurances from the different armed groups? I know Boko Haram is active there, and do we get those assurances?
Well, no. Well, in the Northwest, no assurances at all. In the Northeast, this is where we have insurgency that is driven by ideology. No, we work within what we call the government trench, the military trench. So we don't work outside that trench because we have no assurances whatsoever. In fact, we've had to close some of our programs because we had critical incidents in some of those areas, which is really unfortunate because the folks that suffer in the end are the ones that are in need.
Yeah. Last question for now. I feel like we could talk for a long time on this context, but in terms of the communities themselves, to what extent do we sort of engage with community members and community leaders as we're designing our response? Are they involved in helping us to co-design the kind of response that we deliver?
Absolutely. In all the places where we work, and particularly in the Northwest, we involve the traditional leadership quite a bit, because for us to even maybe function in those areas, we need acceptance from the communities themselves. And so in many ways, and we've worked very closely with those communities, and also we work also closely with the various state government. In every state where we are, we have an MOU with each state government, and so I would say our acceptance is very high from the recipients of our services. But of course, we always run the risk of being in the wrong time, being at the wrong place in the wrong time, and encountering some folks that might have adverse or ill intentions toward us.
Thank you, Dr. Simba. Moving on to Haiti and Rachel Seguin, who is the medical coordinator working in Haiti now. As we mentioned, pretty challenging circumstances for people living in Haiti, especially in Port-au-Prince these days. Rachel, can you similarly just describe a little bit what is life like for people in Port-au-Prince and for our colleagues as well?
Just making sure that you can hear me okay?
Yeah, loud and clear. Thanks, Rachel.
Okay. It's super challenging. I think, of course, Haiti isn't new to having a challenging context, but it's been getting harder and harder. And I think there's certain neighborhoods or areas that have always been known as being quite challenging and difficult, where it happens that our projects are located. But these locales have these challenging contexts have now expanded. So there's places that maybe previously had been deemed safe or safer have gotten increasingly more difficult. So it's harder to know exactly what the situation is, and just either for ourselves or our staff to get around, because the context and the violence isn't just where it used to be, quote unquote, traditionally.
So if you're a resident, of a certain part of Port-au-Prince, and you need to kind of move to another part of the city in order to get health care, what do you have to do, or how does that work?
It can be challenging in itself. And then, of course, in September, the country went through what they call here a pays lock, so which literally translates into a locked country, because there was no more, there was a fuel crisis in that there were protests because of an increased fuel prices, and then fuel was no longer available in the gas pumps. So then it was nearly impossible to get around from point to point B, because even the local transportation was no longer working. So if you thought it was challenging before to get to point A to point B, when there's literally no fuel available for the local population, it became nearly impossible. And then even if you got to the healthcare facility that you were trying to get to, if they didn't have fuel, then the hospital might not be open, because the electrical grid here isn't strong enough to sustain 24/7 electricity, which means most hospitals here are completely dependent on generators as well to be able to function. So even if you were lucky enough or resourceful enough to get from point A to point B, doesn't mean that your destination could provide the care that was.
Right. And at the moment, on top of everything else, there's a pretty large-scale cholera outbreak from what I gather. Cholera, a preventable disease, how has this come about, and how bad is it?
It kind of, like we say, ça enchaîné with the pays lock situation. So we received actually in an MSF facility the first case that was suspected of cholera. We were able to isolate the child pretty quickly and send off the lab test to get the confirmation. And meanwhile, in another MSF facility, they had gotten some suspected cases as well. So it was literally in our backyard, or technically our parking lot, where we were able to start treating the first cases, which was at the end of September. So as some of us might remember, with the cholera outbreak that happened, that was linked back to the earthquake in 2010. It started, I believe, at the end of 2010. So this population is no longer, say, completely naive to cholera. It had just celebrated 3 years without having any cases. And then unfortunately, it's come back. So it doesn't have the completely disease naive population that it did back in 2010. So it's not necessarily as widespread and wide scale as it was, but it's still pretty devastating. And we know that even the cases that we're receiving, it's not the only cases that there are. So I think we're at around 15,000, if I'm not mistaken, ish. Cases so far. Right now, it looks like there's a bit of a slowdown, but we don't know if there'll be a second wave of cases coming up, or in different parts of the country, because once the gas was, although at a higher price, more available, the disease has a better chance of spreading with person-to-person transmission.
Last question. Time really flies here, but in terms of the highly infectious disease, cholera, what does a response look like? How do we actually treat it?
Well, so you need to treat it on different levels. So one, you need a place where once a patient has cholera, that you can treat them in a safe way, where we can isolate them from other patients. So you would never want to have a cholera ward in the middle of a hospital. So generally, we try to put them outside, beside, or in another facility completely. And there's a whole, treatment protocol that we follow. Basically, you're trying to rehydrate people as best you can, depending on how dehydrated they come in, and treat the symptoms. And then prevention is a huge key. So chlorinating water points to make sure that the water people are accessing are safe. Hygiene, so that in-house transmission can be prevented. Awareness and sensitization to the topic, so people know how to protect themselves the best they can.
Thank you so much, Rochelle, and same to you, and same to you, Dr. Simba. Yeah, time really does fly. I feel like we could chat about these crises and MSF's response to them for hours. So this has been our Twitter Spaces focusing on MSF's emergency response in Haiti, Ukraine, and Nigeria. As I mentioned on the top, MSF is responding to emergencies really around the world. We're in about 70 countries at the moment. We could have put a spotlight on the floods in Pakistan or South Sudan at the moment, or ongoing work in Afghanistan, or violence in Eastern Congo, or the search and rescue operations in the Mediterranean, and on and on. But I hope that you got a bit out of this session. If so, please retweet it, share it, like it. And thanks once again to our panelists and for everybody joining. We'll look forward to the next one of these sessions in the new year. Thanks, everyone. Bye for now.